I am Tolullah Oni. I'm a health professional. Are there any health professionals in the room? One and a half. Okay, so I'm a health professional. I would say I started off as a healthcare professional, and then I slowly worked up to the fact that I was in fact a disease professional. And that when we think about health care, that sector is actually burdened with managing existing disease. So I set off on this journey to become a health professional and trying to understand, well, what would that look like and what does that mean? So the first realization to something we intuitively all know, but that over 2/3 of the factors that contribute to health lie outside of the healthcare sector. And so what we actually see in the healthcare sector is this tip of the iceberg of manifestations that are actually going on below the surface, totally outside of our reach. And so this intuitively started seeing this missed opportunity to say, well, if I'm going to become a health professional, that's where I want to be, right? I don't want to wait for the iceberg. I want to get underneath the surface to say, well, how can we actually create health and not just manage disease? I gravitate towards cities because obviously that's where large groups of people are. So I should say I initially, about 12 years ago, went to work in Cape Town in South Africa. After working for several years in disease, I should say, largely infectious disease. And the move was actually to get behind the disease into research, and so that was the pivot for me to get into research, to try and understand these infectious diseases, what the burden is, how they co-occur. So I spent a number of years working in HIV and in tuberculosis research, specifically around epidemiology that looks at understanding the burden of disease and the determinants and how these diseases interact. But then that's where the revelation came that I was just sitting and waiting for these diseases to manifest in the healthcare sector, and that I needed to get out of the clinic and out of the hospital into where the health was actually being created, or the missed opportunities to create the health. So in the context of cities, I thought, well, we're dealing with, across many settings, rapidly growing cities. I started thinking, well, why do people move to cities? It tends to be for employment opportunities, for education, for access to services, right, that are concentrated, health, social, etc., and for a social network, so for personal reasons. But I started realizing that whilst these are on the surface, why people move to cities, what they in fact got was a different set of exposures. Now, I should caveat to say that epidemiologists always think about things in context of exposures and outcomes. So when I started thinking about a city, I thought, well, what are the exposures that characterize a city? And that's the first thing. The second caveat, I should say, was I started off thinking around the food, then sugar and salt, and then there were 2 S's, and then I was committed to the S's. So some of the S's are a little bit contrived, but you'll remember it a bit better. So I started thinking about what are some of the, this is not exhaustive, but what are some of the important urban exposures, and in what ways do they relate to the common population ill health that we see? So, for example, the sugar and salt kind of best characterize the food environment in the context of the unhealthy food exposures that drive really the epidemic of diabetes, hypertension, and obesity that we're seeing really the world over. In the context of rapidly growing cities across Africa, where most of my work is, we see this even more so. And I don't think I need to tell this audience, it's a fallacy that these are diseases that occur in the wealthy, because actually we see a disproportionate burden of diabetes and hypertension in the poorer people within cities. And I think that bears out in London as it does in Cape Town and New York. Sports and recreation speaks to how people move and physical activity. So the ways in which the convention center makes you walk along a while, but it prevents you from sitting. Musculoskeletal disorders, back pain is really one of the top contributors to ill health. So disability-adjusted life years is the way we think about beyond mortality. How do we think about suboptimal health? So back pain, chronic back pain, is really by far and large and globally an important driver of ill health. Sleep or lack of sleep and stress driving this cardiovascular disease, really impacting on mental ill health. So this is one of the most silent epidemics worldwide. I tend to focus not on mortality, but on morbidity, because mortality grabs your attention because people are dying, whereas morbidity is the absence of health. Safe housing and social cohesion as very important. Smoking, obviously, smoke, air pollution. So looking at the ways in which these exposures drive air pollution, for example, in rapidly growing cities in Asia is one of the leading causes or contributors to the rapidly growing prevalence of strokes. So I started asking, well, if this is what a city is, and these are the kind of exposures that people are exposed to, and you've seen the ways in which they can drive ill health, can they be harnessed to positively influence health? And if yes, how? And who's going to do that? Who sees it as their responsibility to create health in the context of the city? So just to give you another, sorry, I'm not good at standing still. Just to give you another public health conceptual framework, I think, again, intuitive, and different disciplines have different forms of this, but this is called the socio-ecological determinants of health. And just to highlight that when I talk about drivers of ill health, very often, when we talk about in general, very often we stick at the individual level. What people know, what people, their attitudes about certain things, their beliefs about certain things. And that is what often drives our interventions to improve health. But I like this onion skin because it shows that that is but one layer. And that in the context of cities especially, it's important that we consider the other layers, so the interpersonal layers, the ways that people interact with each other, the broader environment and how people engage with that, and the broader structural policy environment within which people exist. Because the choices people make, and I say choices, quote unquote, because it isn't always that way, the choices people make are very much nested and embedded in those environments. So my research essentially looks at how can we make the healthy choice the easy choice. Anyone who knows me knows I dislike the term diseases of lifestyle, which is how we sometimes think about diabetes and hypertension, because very often people make the most rational choices for the environments that they're exposed to. So how can we think about better ways of creating health and making that individual choice, giving the option of making the healthy choice, not the difficult one to make? I drew this. It wasn't a 3-year-old. It wasn't my niece. I drew it. This is the extent of my artistic repertoire. But I use it to show this concept of healthcare as being right at the end. So the blue is the water. Yeah, you with me? Healthcare as being right at the bottom of the water, rescuing people that are drowning. But I see the city and the built environment is behind that, often built in a way that pushes people off the cliff. It says, oh no, there's an ambulance in the bottom, don't worry. Right? But it makes sense to say, well, not only do we look at how to stop cities pushing people off, but, oh, I don't think I put the other one. No, I didn't. I have another one as my second attempt at animation, where I then drew the city the other way around, to show how the city can not only not push people off, but actually protect and create health. So it's not just about harm reduction, but actually positively creating health. So these ramblings are what informed the establishment of my research group, which is RICHE, which just looks at cities' health and equity. Equity I added there because I think it's important that we contextualize the health that we seek to create and ensure, if we're thinking about health, we're thinking about where ill health most often occurs, and we're trying to address that burden. So if we say there is a global, beware of averages, if we say in this city there is a significant obesity problem and physical inactivity problem, is it enough to just put bicycle lanes in? Is it not enough to just do something wherever? Will that impact at a population level if it's not actually connecting with the populations where the ill health occurs? So the two aspects of what I do, the first is maybe more intuitive from a health perspective, looking at health systems in cities, because what we see is that these exposures drive changing patterns of disease, what is termed epidemiological transitions, so moving from infectious to non-communicable and the ways that they interact. So I look from the health systems perspective, from the context of the healthcare system, to look at how that delivery can be better responsive to those changing population health needs. But I also look at systems for health to say, well, what are the systems in the urban space that can be harnessed for health creation, and how can we work together and collaborate to make that happen? So examples at the moment, looking at food systems governance, so we're looking at, in particular, to just give an example of one project, looking at adolescents and how they move through the city, particularly trying to understand the school-going adolescents, their food exposures, particularly then within the context of the city, from the environment, trying to understand what govern those, the availability and the patterns of food production and food access, to identify the levers in the urban environment that can actually reach adolescents. Because if you try to talk to an adolescent, a teenager about diabetes, I mean, right? So how can you understand the way that they interact with the urban space in order to make them the future advocates for healthy food environments? We've also done some work largely with the public sector, but increasingly public and private, looking at health and human settlements planning. So in the context of Cape Town, where there is a lot of informality and there is a move towards thinking differently about informal settlements, from getting rid of them to actually upgrading them and thinking differently about that. Now, that is normally in the context of services, which are very important. But we co-created some research with the policymakers to look at, well, what are the opportunities for impacting on the food environment? and the physical activity environment, how people move through, whether that's for leisure or for commuting. One of the interesting things about lots of cities in Africa is because it's one of the least urbanized continents, but is one of the most rapidly urbanizing. So the conversation around urban policies is starting. And so, for example, we've worked with the East African region that are in the process of developing an urban policy to look at how do we ensure that the health of the population is at the center of that. Because we cannot afford to treat ourselves out of every epidemic we create. So how can we stop creating them? That's the first bit of my talk. That's most of it, actually, so don't worry. The next bit, I am just reflecting a little bit before I came, but also on some of the presentations that came before. I created this word cloud from some of the presentations before the break. And in thinking about the role and potential contribution of architects to health creation, I thought I'd use your words and weaponize that for health. Okay. Firstly, SDGs. I was so pleased to hear about that, because I think the SDGs have done a lot for thinking about interdependencies in terms of the challenges that we face societally, of understanding that these issues are not siloed, but that actually they interact. And so I know the most obvious, for example, SDG, I'll come back to the word cloud, is in the context of architecture and urban development is SDG 11, which is around sustainable cities and communities. But I like this partly because it puts my mission in the center, but also because it's a really great way of thinking about the interaction between some of these SDGs. So for example, yes, it interacts with SDG 11. So I'm sure the text is too small, but the texts actually come from the goals of the SDGs. So whereas 11 is around fostering healthier cities, we also have 17, which is around partnerships. I can barely read them. Partnerships to achieve the SDGs. 4, around education. I loved the presentation earlier around thinking about a different way of educating the next generation, because what we need is health professionals from different disciplines and from different contexts who understand the complexity of what it takes to actually create health, who understand that it's not just going to medical school, studying a health science that creates health, quite the opposite, and who understand the importance of working together and collaboration in order to create health. So just going back to these. History, hope, emotion. Those are 3 words that really struck me from some of the presentations that repeated the importance of history. I loved what you said, Kate, about spatial unease. I tend to think about it in the context of dis-ease, because it's a great pun on disease. And helps me think about, well, if disease is a state of dis-ease, how can we create ease? History is an important thing I've learned along the way. So in some of my work in Cape Town, understanding that spaces and places have history. The places have history objectively. The people who interact with the spaces have their own history. And the interaction of the people in place have history. So then when you think about upgrading or developing or creating something new in this space, how often do we engage with the history of the place and engage with the history of the people who will be using that place? Because otherwise, you might end up with something that's built that wins lots of awards that nobody uses. And you wonder why, right? Needs. This is a really good and important one. Has anyone heard of Hans Rosling? Right? So he was an incredible just educator, communicator, he was an epidemiologist. His tagline was fighting devastating world ignorance. And I had the pleasure, he passed away a few years ago, unfortunately, I had the pleasure of hearing him speak in a small, not too dissimilar to this size room. And he has this clicker test that he gives the audience. So he asks, so it was a room of scientists, right? So we were a room of lots of different disciplines gathered around from across the world, about 50 people. And he says, well, you're all here because you are committed to looking at how to harness your science to improve society. So let's see how much you know about society. And then he proceeded to ask us some very basic questions. All I can say is I'm really glad they were anonymous. Questions like, what is the average life expectancy in the world? What proportion of under 5s are immunized? What proportion of girls complete primary school? We woefully failed. I mean, I think he loves to point out that we did worse than chimpanzees, just random. And this sentence really stuck with me. He said, how can you improve the state of the world if you don't know the state of the world? And that really stuck with me because in everything I do, and I'll think, well, what do we know about the needs of the people who are using that space? And obviously from a perspective of health, so say, for example, in the workplace, if you're looking at building workplace, we were talking earlier about where we spend most of the time. What are the most common causes of absenteeism in that workplace? Where are people coming from spatially to gather in that workplace? What are the opportunities to actually create health and address some of the environmental deficits that may occur where they live? If we don't understand the health needs of the people who use this space, we miss an opportunity to create health. Related to that is advocacy. I teach my students, so a core part of what we do is community health, and it's often the first time some of the medical students have gotten out of the tertiary hospital and into the community. And then they come back and they just want to be advocates. I'm like, well, what is who is responsible for resource allocation? Who do you go to if something isn't right in the clinic? How do you, if you don't know your landscape, how can you be an effective advocate? So this is related to needs, understanding the needs of the population, but also understanding the landscape beyond the space that we're working in to impact that. The last thing I will highlight from this is empathy. And that really speaks to the equity perspective. Something is not always better than nothing. And it's important that when we go into space, that sense of empathy to understand what people need, what people's histories are with the space, can be quite powerful in creating health. Okay, this is my last slide. So I started off talking about health professionals, and I started off with that first slide of what the health professionals look like and that I'm a health professional. The 4 key things that I want to leave you with is, firstly, the cities are determinants of health. Secondly, that most factors that contribute to health lie outside of the health sector. Thirdly, that many of these lie in the built environment. And fourthly, that this makes professionals, here's looking at you, working in this space, de facto health professionals. You might not be a healthcare professional, but that's okay because that's mostly disease. But you are health professionals. So the next time when you think about health professionals, you see this, you see that, and then you autocorrect, because some of the scientists that I work with, I have the same message: you're a health professional, how do what you do impact health? Politicians, very much health professionals, because the decisions that you make impact on health, and that drives a lot of the collaborations that I have in my research. Food producers, very much health professionals, right, along the continuum of the food system. And you knew it was coming. Architects. So I'm going to ask the question one more time. How many health professionals are in the room? My work is done. Thank you.